Good morning. My name is Nick. I'm a PhD student at the University of Michigan. I'd like to present our work on developing a machine learning algorithm to detect patients with acute respiratory distress syndrome. In particular, we're interested in incorporating clinical uncertainty from a medical diagnosis in a machine learning process. So, acute respiratory distress syndrome, ARDS, is a severe lung injury that's characterized by inflammation or a diffuse alveolar damage. So you can by diffuse alveolar damage. So ARDS, sorry, this is kind of wrong. But yeah, you can see these chest X-ray scans, which are the gold standard for detecting ARDS patients. However, this information is not available to physicians at the entire time. So instead of relying on chest X-ray scans, we proposed a machine learning algorithm that could possibly account for uncertainty in a diagnosis. So in this example, or in here, this is coming up in the wrong order, I'm sorry. But like many other problems in the medical domain, there's always a degree of uncertainty associated with your diagnosis. So some of the labels that you feed your machine learning algorithms might be corrupted, or there might be a degree of uncertainty associated with this. And because of that, it might fool the algorithm to make false predictions or to make predictions incorrectly. In this case, in addition to the physicians actually annotating their labels, we ask them to rate their degree of confidence or uncertainty as well. So here you see that if the physicians also gives their rating as a 1, they might be totally sure that ARDS is not present in your patient. And if they rate the score as an 8, they are totally sure that ARDS is present. So 4 or 5 might give more ambiguity or uncertainty in your diagnosis itself. We use this weight of uncertainty and confidence in forming the decision plane for a machine learning algorithm. So points where we're totally sure is correct, we might put more emphasis on. And data points that we aren't sure about, or kind of fuzzy, and we don't have much confidence in, we might treat these differently. Maybe we can penalize them differently, or we can alter their loss function to account for this information. And before I move on, I do want to emphasize that even though in this study we focus our topic on ARDS, this problem of uncertainty in the medical diagnosis is really generalizable across many domains in medicine. So when you're developing a machine learning algorithm that's relying on clinical support or for your physicians to annotate their labels, there could inherently be some uncertainty or some mislabeled data points, and that itself could adversely affect your algorithm. And here we show the protocol for our algorithm. It's your typical 5-fold cross-validation with testing on holdout data. And we do some basic standard pre-processing like normalization and data scaling. But before moving on, when we started working on this project, we realized that there was an inherent problem of overfitting to the data because we're working with time series data from patients. My PI suggested that maybe because you're measuring repeated measurements over time, that these repeated measures could inherently bias your model and violate the IID assumption. So what we do to address this is that we kind of implement a selective sampling strategy based on mixing in mathematical stochastic processes. It's a pretty lengthy explanation, but I've included some pseudocode in our poster outside, which goes into this in very clear details. And here are our results for implementation of label uncertainty with support vector machines. To account for label uncertainty, we incorporate that value into the penalty parameter C of SVM, where points are associated with high confidence. We do give more weight, more emphasis on. That way the classifier prioritizes on getting this correct in the decision plane. And points associated with a lot more uncertainty or lack of confidence in the diagnosis, we give less weight to. And in here, we report about a 10% increase in area under the ROC curve when comparing SVM with and without label uncertainty. We benchmark the algorithm specificity at 95 and 90% sensitivity because we wanted to make sure that we didn't miss any cases of ARDS. So if this is interesting to you and if you have any questions, please come by to talk to me at our poster outside. Thank you.